Bismillah ar-Rahman ar-Rahim. This is the second session for radiotherapy course. I'm glad to introduce our mentor and our boss, Professor Muhammad Saad Zarloul, Professor of Radiation Oncology, National Cancer Institute, and Director of Radiation Oncology in 57 hospital. We'll talk about ultra-hypofractionation radiotherapy for prostate cancer.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizers, Professor Khalid and Professor Reem, and our chairman for this nice introduction. Today I'm going to speak about the hypofractionation and ultra-hypofractionation for the prostate cancer. All of us know that the NCCN risk categorized the patients, the clinically localized patients, into very low, intermediate, high, and very high. And for simplicity, it's always low, intermediate, and high. So, and this is the characteristics of the each category. For the low and the active monitoring is the treatment of choice, and for the active treatment for the intermediate and high-risk patients are the radical prostatectomy, radiotherapy, or combinations with androgen deprivation treatment, and the advanced disease are treated with androgen deprivation treatment and combined treatment. First of all, I would like to emphasize that the level 1 evidence show us that the radiotherapy is as equal as surgery in localized prostate cancer in terms of disease-free survival as well as overall survival. Probably the toxicity for radiotherapy is much lower, although this is not the subject of our discussion today. The timing of the androgen deprivation treatment and radiotherapy, as you can see here, is the radiotherapy comes in between the start of the ADT and the continuation of it. And we usually use a single LHRH agonist plus minus anti-androgen. And the bicalutamide is not having any role alone in such case. The current radiotherapy level of evidence that we can see here that the intermediate risk must be treated with a high-dose radiotherapy or radiotherapy with short-term ADT, from 4 to 6 months. And this is a level of evidence 1B. While the high risk and also the very high risk, the radiotherapy plus long-term for 2 to 3 years ADT, and this is of level 1A evidence. The dose has to be very high, reaching up to 80 gray. And you can see here from these two cartoons that for the intermediate risk, the 78 is much better than the 70 gray, while in the high risk, the 78 is much better than the 70 gray dose to the prostate. We know also that the tumor has an alpha-beta ratio of 10, and we know that the normal tissue have an alpha-beta ratio of 3 to 6, but for the prostatic cancer, the alpha-beta ratio is between 1.5 and 3. And we can have benefit from this knowledge much by doing the hypofractionation. As you can see here, the fractionation is from 35 to 45. This is the conventional fractionation, and the hypofractionation and the SBRT, or the ultra hypofractionation, is from 1 to 5 fractions, while that in between is the moderate hypofractionation. It's usually 20 to 25 fractions. This definition has been introduced by our colleague, Dr. Ihab Khalil, and so it's the same. And for the extreme hypofractionation, giving 5 fractions per treatment is started in 2000, and the first patient was at that time having the 5 fractions. At 2009, phase 2 trial results appeared, and in 2014, the NCCN and ASTRO giving the guidelines for this is recommended, the SBRT is recommended, and then comes the hypo-RT trials, and in 2019, a report of more than 6,000 patients has been published. Here we can have an example of the early studies of the SBRT using the CyberKnife, giving 36.25 gray in 5 fractions in 1 week. And these results are biochemical control is 100%, and at 12 months, and the BSA nadir reached in 78%. And in another more study, including 112, the dose was between 35 and 36 gray per in 5 fractions, and 3 patients only has failure, 2 has local failure, and 1 has distant metastasis. And the erectile function is 82%, more than that in the normal population. There is 2 randomized trial which has established this ultra hypofractionation. One for toxicity and tumor control, and the other one is restricted to toxicity. As you can see here, the toxicity of the GI as well as the GU, the toxicity is not different at all from the IMRT. So the hypofractionation gives us the advantage of extreme or ultra hypofractionation without the effect on the normal tissue surrounding the tumor. The other paper is showing that the ultra hypofractionation giving 72.7 gray in 7 fraction, 3 days per week for 2.5 weeks gives the same results of the overall survival as well as the biochemical free, relapse-free survival than that of the conventional fractionation, giving 78 gray and 39 fraction. So as I just mentioned, the ASTRO, NCCN, and AERO guidelines have included ultra hypofractionation, or what we call SBRT, as an option for prostate cancer. But it has to be in center with technology and clinical experience. So to understand why we give the ultra hypofractionation or the CyberKnife, if we go to cartoon number 1, we will find that the prostate is surrounded by the bladder, rectum, bowel, and so when we give the with IMRT, we included part of these tissues, and this will cause toxicity. With the SBRT, we have much less of this irradiation of the bowel, bladder, and the rectum. While in the CyberKnife, in cartoon number 4, you can find that there is almost nil of irradiation of the surrounding tissue. That's due to the tracking characteristics of the CyberKnife, and for the intrafraction adjustment that goes through all the time for CyberKnife. This is the CyberKnife. The CyberKnife is a linear accelerator mounted on a robotic manipulators, and is guided by 2 orthogonal X-ray sources that takes a picture every 5 to 150 seconds, and it modulates the position of the patients according to this and give the treatment after that. This was synchronized by a camera. And there is, of course, a robotic treatment couch that do both the translation as well as the rotational adjustment. How is the technology different? The advanced interactive robotic of the LINAC with a real-time imaging every 5 to 150 seconds, and usually it is 20 seconds. Dynamic automated motion tracking, as I just mentioned. Flexible and accurate LINAC multiple beam radiation delivery. And the robotic couch for more automated and accurate radiation. The Fudicial has to be put on in the prostate. Sorry, and by the way, this lecture is 20 minutes, not 15, so you have to correct this. The Fudicial has to be 20 millimeters apart from each other at least, and we have to have the angle more than 15 degrees in order to get this correctly done. We do the MR simulators together with the CT simulators, and then we have the target contouring for the prostate and seminal vesicle if we take the whole seminal vesicle or the lower two-thirds of the seminal vesicle. We have to delineate the rectum, bladder, femoral heads, as well as the prostatic urethra and penile bulb. The ice dose distribution is done, and it's done for those who are doing it. It's not that complicated. It's more complicated than the other planning, but you can master it if you do it quite often. The doses of the radiotherapy is, as I just mentioned, the most famous is 7.25 by 5 gray, and but you can have a range of doses, and this the BED ranged from 168 up to 312, and the one that is marked by red is done, but it's not oftenly done, and the giving one treatment of 24 gray is done only by one person, which is Greco of Lisbon. So nobody else do this, and eager to do it. The NCCN guidelines, this is as I just mentioned the CyberKnife as the an option. Here we monitor the late urinary toxicity for the SBRT versus the IMRT versus the brachytherapy. And you can see for those on the left-hand side, the toxicity of the urinary toxicity is much less than that of the external beam radiotherapy, as well as much less than the brachytherapy. The late GI toxicity is the same. Here is the very minimal toxicity of the CyberKnife. Mainly, it is grade 2. Ranging from 1 to 4.6%, while for the external beam, it is around more than 30% for this, and there is some of grade 3. The brachytherapy is 5%, so it's still better in with the CyberKnife. This is the prospective trial from 10 institutions with a total dose of more than 2,000 patients, and the 7-year progression-free survival, biochemical relapse-free survival was 95.5% for the low risk, 91.4% for the favorable intermediate risk, and 85% for the unfavorable intermediate risk. If we compare the CyberKnife to the high-dose rate brachy, the low-dose rate brachy, IMRT, 3D conformal radiotherapy, and even the proton therapy, we will find that the CyberKnife has the 5 characteristic is the continual imaging guiding throughout the treatment. This is only for CyberKnife and brachytherapy. It's non-invasive. It's treatment time 5 times or less per treatment, and doesn't require anesthesia and doesn't require operative procedures. The isodose distribution, here you can see comparison between the CyberKnife and the IMRT. The CTV is nearly the same. The bladder is better, but it's not statistically significant. The rectum is better with a statistically significant difference. The conformity index and the homogeneity index is better for the CyberKnife than the IMRT. However, the normal tissue constraints has to be done for the hypofractionation, not for the ordinary fractionation. So the constraints are different, as you can see here, and even you have, it's always done revision of these constraints in order to be treating your patient safe. You can have the images, you can have SBRT for recurrent disease, as you can see here. Don't know if this, you can, here you give the radiation to the recurrence, and this will be very successful. And the prostate radiotherapy should be a standard treatment option for men with newly diagnosed disease with a low metastatic burden. You can irradiate the patients with radiation when he has an oligometastasis also. So, of course, the limitation have some limitation. CyberKnife have some limitations. No posterior undercouch shooting, more complex planning. It's long treatment time, but this treatment time is controlled by the intrafractional imaging that it corrects for the position of the patient. and it needs significant quality assurance for the treatment and for the robot, and all not only the planning, but for the machine itself before each patient. So on conclusion, using the CyberKnife dose-escalated prostate SBRT is safe with a low rate of serious side effects. Quality of life outcome shows a brief acute effect on the GI and GU quality of life. Urinary irritative symptoms at 1 year is completely resolved. 5-year biochemical relapse rate following SBRT are very favorable compared to historical data. CyberKnife SBRT is a suitable option for low and intermediate risk cancer. And I will say for even the high risk, except if they don't have any lymph node metastasis. Although the high risk is preferable to do it in a clinical trial. This is the ASTRO, the ASCO, the AU have an evidence-based guidelines, and these guidelines shows that the hypofractionation should be offered for low, intermediate, and high-risk patients, not including the pelvic lymph nodes. And the outcome of the clinical trial shows that the dose doesn't, the high-risk prostate cancer, the task force doesn't suggest offering ultra hypofractionation outside the clinical trial, although there is a lot of clinical trials showing that it is successful in high-risk patients. The ultra hypofractionation of 35 to 36.25 gray in 5 fractions of to the planning target volume may be offered to low and intermediate risk patients with prostate size less than 100 cubic centimeters. 5 fraction prostate ultra hypofractionation using consecutive days treatment is not suggested. And we are not doing this, we are doing day after the other. Due to potential increased risk of late urinary and rectal toxicity. IGRT is universally recommended when delivering moderately or ultra hypofractionation external beam radiotherapy. CyberKnife offers continuous interfraction verification through tracking characteristic. And thank you very much, and these are our CyberKnife.
Thank you, Professor Muhammad, for this comprehensive lecture. And I think we are beyond schedule. We can keep the question till the end of the session. And thank you very much.
So we're moving to the next speaker, my dear colleague from Alexandria now at Loyola Cancer Center in Chicago, Professor Dr. Tamer Refat. This is a recorded presentation. He will try to be online at the end, we are not sure. He will present to us today updates in pancreas cancer radiation therapy.
I would like first to thank very much Dr. Rima Ahmed and Dr. Khalid Abdelkarim for the kind invitation to give a presentation today about the current role of radiation therapy for pancreas cancer. Given the limited time, 15 minutes, I will try to highlight the current status and we'll go through a study that we're running at my institution at the Loyola University in Chicago. So as you all know, pancreas cancer is a highly lethal malignancy. It is the third leading cause of cancer deaths in the United States and of course in Europe. Surgical resection remains the main potentially curative treatment. However, only 15 to 20% of patients who present presents upfront as a surgical candidate. While distant metastasis happens in more than 70%, local progression is a real problem. It accounts for more than 60 to 50 to 70% of patients and results in significant morbidities, including biliary and vascular invasion or gastric outlet obstruction. In an intriguing study coming from Johns Hopkins, 30% of patients with locally advanced pancreas cancer did not develop distant mets and died from local progression. So local control is needed in pancreas cancer. Many studies have shown that at least 50% of patients, if not more, develop local progression at a certain point of time during their pancreas cancer progression. In an NCDV analysis, arterial resection is proved to be of ultimate importance. It significantly improves overall survival at 1, 3, and 5 years. Positive margins predicted poor survival, regardless of the stage or the receipt of any adjuvant therapy. Neoadjuvant therapy improves the likelihood of R0 resection. For locally advanced pancreas cancer patients throughout the years, many studies, retrospective phase 2 studies, try to identify an optimal approach. Chemotherapy followed by chemoradiation in these patients. Lab 07 study was a prospective study, 2 by 2, comparing gem to gem plus erlotinib, and then adding radiation or without radiation. While the study was a negative study, it showed that gemcitabine alone is not enough. Erlotinib did not work. Radiation therapy at a dose of 50.4 conventional dose did not really result in significant toxicity, but did not add much as well in the gem era. Curative doses of escalated radiation might be needed, and definitely there was a need for systemic therapy that is better working than gemcitabine. SPEC4 is in the adjuvant setting, it's a study comparing gemcitabine to gem plus capecitabine, adding some modest improvement in survival of 3 months. However, if you note here, 60% of patients ended up with positive margins. We do not see that in pretty much any other tumor site. It's not acceptable, but we frequently see this in pancreas cancer, and we know that this significantly results in inferior treatment outcomes. PRODIGE study was a study comparing gemcitabine versus FOLFIRINOX as an adjuvant therapy for pancreas cancer patients. The study included approximately 500 patients. It doubled the survival. We haven't seen a median survival of almost 55 months before in pancreas cancer, so it was a great study putting FOLFIRINOX as a standard in pancreas cancer. However, patients in gemcitabine arm also had significantly better average median survival of 35 months compared to historical 22 and 25 months, which might show some selection bias here in selecting like better performance status patients to enroll in PRODIGE study. However, even with this, we again saw that 40% of patients had a positive surgical margin. So if that would have been addressed to improve this, likely that survival would have been better. Now, there are many challenges to adjuvant systemic therapy in pancreas cancer. 10 to 20% of patients who are scheduled for surgical exploration do not undergo resection because of finding metastatic or locally unresectable disease at the time of surgery. We know now there is an evidence that radiological assessment before surgery is not really very precise. It does not give a great insight what you will see at the time of surgery. An exploratory laboratory also comes with significant mortality and morbidity, which might reduce the quality of life. And many patients do not recover from resection in a sufficient time to start adjuvant therapy within 12 weeks after surgery. And we see up to 50% recurrence of metastatic disease 6 months out of surgical resection. So the concept of neoadjuvant systemic therapy came, and this is a study of our very own Dr. Small of Loyola, which was published in JCO back in 2008, trying to incorporate neoadjuvant radiation therapy to gemcitabine And the study was a phase 2 study, and the outcomes were very tolerated. It did not show significant toxicity for neoadjuvant radiation as part of the neoadjuvant therapy for pancreas cancer. A meta-analysis included prospective and retrospective studies. Most of the studies are actually retrospective. Approximately 3,500 patients, 50% of them had neoadjuvant therapy. The median overall survival by intent to treat improved with neoadjuvant therapy compared to upfront surgery. The difference was larger among patients who underwent tumor resection. R0 rates again improved survival, and R0 resection here was higher when using neoadjuvant therapy, up to 86%. And non-zero resection or non-positive rate for neoadjuvant therapy was less than with upfront surgery, was 20%, which was statistically significant. BrioBank study is a study comparing upfront surgery to neoadjuvant chemoradiation. So surgery and then adjuvant gemcitabine to GEM plus GEM-RT surgery and then more chemotherapy. That actually was based on the protocol of Dr. Small's study. And it included patients with resectable or borderline resectable pancreas cancer between April 2013 and July 2017. I'm sure I'm trying to monitor the time here. 246 patients from 16 centers randomly assigned to this study. In the initial result, that was a negative study. Primary endpoint of overall survival by intention to treat was not met. It was published in JCO in 2020, 16 months versus 40.3 months, not statistically significant. Everything else was better. R0 resection was better, 71% versus 40%, quite significant here. Neoadjuvant chemoradiation improved disease-free survival, local control, PNI, LPI, and positive node rate. However, in a recent update, which was published this year in JCO, at the median follow-up of 59 months, there was a statistically significant improvement in overall survival as well. So while neoadjuvant chemoradiation improved survival, remember this study was comparing neoadjuvant chemoradiation to upfront surgery and adjuvant chemotherapy. It was including gemcitabine, which we know is not the best therapy now for pancreas cancer. The effect of neoadjuvant chemoradiation is consistent across the pre-specified subgroups, including resectable and borderline resectable pancreatic cancer patients. This led to the design of BioBank 2 study, which is comparing 8 cycles of FOLFIRINOX stent surgery in the neoadjuvant setting to the winning arm of the BioBank 1. Again, I don't think that's a fair study because we know that FOLFIRINOX works better than gemcitabine, and there is no radiation component in this arm here. And then we have OncoEgypt study, which was a randomized phase 3 study, including induction chemotherapy followed by chemoradiation or chemotherapy alone for non-resectable locally advanced pancreatic cancer patients in the neoadjuvant setting. Again, disease-free survival and overall survival were significantly better for patients with R0 resection, highlighting the importance of having negative margins. The primary endpoint was initially overall survival. They had poor accrual. They had to change the primary endpoint to R0 resection, which was helped by radiation. Many other prospective and retrospective single institution studies showing the benefit of chemotherapies and surgery or chemoradiation and surgery. So what is the RT rationale? Improved systemic therapy, either FOLFIRINOX or gemcitabine, increase the need for local control. Patients are living longer, they have higher rate of local recurrence, they need better local control. Local progression has consequences, primarily bad quality of life and the end of life situation for those patients. And R1 resection impacts survival clearly. Now, this was a feasibility study by Alliance A021101 aiming to see if they are able to accrue patients for this complex study. And they were able to do that, which led to A021501, which is a simple study testing preoperative 8 cycles of FOLFIRINOX with reassessment in the middle to make sure the patient is not metastatic, or 7 cycles of FOLFIRINOX followed by hyperfractionated radiation therapy. They used the radiation of either SBRT 33 to 40 gray 5 fractions or hyperfractionated image-guided therapy 25 to 5 fractions. When the study was designed, they planned an interim analysis that only after 30 patients in each arm with R0 resection is performed in 11 or fewer patients. In either arm, the arm closes prematurely. And that actually happened to their surprise, our surprise, the chemoradiation arm, which led to closure of this arm. Of course, it was a negative study for chemoradiation. It just highlights the importance of avoiding interruption of chemotherapy as well. Like, we are now using higher doses for radiation than what is used in this study, but also we would like to avoid any interruption of systemic therapy. So these patients had a quite of a chemotherapy break from cycle 7 to surgery to accommodate for the radiation. We have some data also that dose escalation for pancreas, locally advanced pancreas cancer improves survival actually. Retrospective data from MD Anderson, however, if they are able to safely escalate the dose to more than 70 gray biologically effective dose, that resulted in significant improvement in overall survival at 2 years, 3 years, and recurrence-free survival as well. There are many data for SBRT in pancreas cancer showing the benefit of dose escalation, including the incorporation of MRI-guided radiation therapy in operable settings. It is very important to make sure that we are mindful we are not using very tight margins here. So there are data from MD Anderson and Cincinnati showing that if you treat only the gross pancreatic disease, ignoring elective nodal irradiation, you might have significantly higher local failure compared to when you combine intermediate risk volume PTB and treating your regional node celiac SMB. So when I started treating patients with MRI guidance, 50 gray 5 fractions with gating and real-time line adaptive treatments, we started with just treating the GTB, and then now we switch it to our standard now to include the celiac and superior mesenteric arteries and intermediate risk volume. Usually I would deliver 50 gray to the gross disease and 30 gray to the intermediate risk volume. So what are the challenges for dose escalation in pancreas cancer, especially that MRI-guided technology is not widespread everywhere? Set of uncertainties, nearby organs at rest, respiratory motion, interfractional motion, and the higher risk of surgical morbidity if you do that in the preoperative settings. So what is the current status of pancreatic cancer? Modern chemotherapy protocols resulted in an unprecedented outcomes with median survival than 50 months. Should always get the patient to surgery whenever R0 resection is possible. We should always aim for R0 resection. We should not delay or interrupt systemic therapy. So is there any way to incorporate or optimize local control of radiation therapy without interrupting systemic therapy? This is the whole rationale for our study at Loyola in Chicago. There is some data which is an intraoperative radiation therapy study, phase 1, phase 2 study, still early to incorporate it in daily practice. But there is some data from Italy and Japan showing the benefit of intraoperative radiation therapy. I'm not going to go through that for the interest of time today. But there was significant improvement in local control and overall survival, R0 resection compared to historical data. Utilizing intraoperative therapy comes with some challenges, including moving the patient during the Whipple surgery from the OR to the radiation department. That is not optimal or doable. We use low kilovoltage intraoperative radiation in our institution, intrabeam. We use either flat or spherical applicators. Sometimes we use surface applicators. During the time of surgery, intraoperatively, you do not need to move the patient. Patient will receive their standard protocol if they need to go through neoadjuvant chemo first, and then when they come for surgery and the surgeon is done with his part, they will identify the area a higher risk of R1 resection, and we will deliver a dose anywhere 10, 15, or 20 grade to this area. So our study is a phase 1 prospective study. Neoadjuvant chemotherapy is permitted, dose prescribed to 2 millimeter depth, and risk stratified adjuvant chemoradiation is planned for R1 resection, node positive disease, or any other institutional standards, started by 10 grade, then 15 grade, then 20 grade. Inclusion criteria including resectable, borderline resectable pancreatic cancer patients, stage 1 to 3. Exclusion criteria includes defined treatment area cannot be adequately covered by radiation field. Our largest applicator is 6 centimeters. So if you cannot cover an area of gross or microscopic possible R1 resection, then we should be abort. We do not treat these patients. Otherwise, that was also like that is an exclusion criterion. Adjuvant radiation therapy, patient with stage 4 disease, immune suppression, and some other standard exclusion criteria. Again, dose escalation from 10, 15, and 20. And now we are planning for a multi-center, multinational actually, phase 2 study with the same idea. So my take-home message today is that systemic therapy resulted in unprecedented improvement in survival, comes with the limitation of 40 to 60% R1 resection and up to 30% death from local recurrence. Improved systemic therapy definitely increased the need for local control. R1 resections limit the progression. R1 resection limits the progress made by systemic therapy and decreased survival. Local recurrence remains a problem. Radiation therapy improves local control, increased likelihood of R0 resection, and likely improve quality of life. Timing and dose of radiation therapy are still to be explored and optimized. Radiation therapy dose escalation seems to provide better outcomes if technically feasible and safe. Delaying or interrupting chemotherapy to offer radiation might negatively impact treatment outcomes. Low KPI to be followed by risk stratified adjuvant chemoradiation might be a solution to optimize local control and avoid risk associated with chemotherapy delay or interruption. And by that, I would like to thank my colleagues at Loyola University in Chicago, and thank you very much. I'm sorry I couldn't be with you this morning given the time difference. However, please feel free to connect with me by email if you have any questions. Thank you very much. I appreciate it.
Thank you, Dr. Steiner, for the comprehensive presentation. Dr. Mustafa Abdulaziz, unfortunately, will be not able to present today, so we'll move to the next speaker.
Next speaker is our colleague, Dr. Marwan Tolba. He's assistant professor in radiation oncology at Dalhousie University in Halifax, Canada. He will speak to us about should we include pelvic lymph node treatment to prostate bed salvage radiotherapy or not. Welcome, Dr. Marwan.
شكرا. مساء الخير لكل الناس. ما اعرفش انتوا سامعيني ولا لا. اعتقد انه مساء الخير. Thank you everyone for having me today. Actually, I would love to be in person with you and in-person chat with my friends, colleagues, and my professors, teachers in Egypt. Today, I will discuss with you one of the, let's say, vague topics and gray zone topic in our practice as radiation oncologists, especially the young generations of radiation oncologists who are not specialized in GU cancer might not be fully aware of certain definitions, especially with the recent evolution in the topic. I'm sharing my screen with you. I hope you can see my screen. Please let me know if you have any issues with that.
Yes, we can hear you very well.
Okay. Great. So today I will discuss with you post-prostatectomy, salvage radiotherapy. I will go over the cutting-edge practice in the world and what we are doing here in Canada. For those who don't know me, I'm Marwan Tulba, an assistant professor here
Yes,
in
if you
the
can raise your voice a little bit, Dr. Marwan, it will be better.
Okay, okay. So these are my disclosures as a consultancy and honoraria. Actually, studies show that 30 to 50% of prostate cancer patients will have, at certain point, biochemical recurrence after they are treated with prostatectomy. We know that a large portion of the patients may choose prostatectomy for their prostate cancer treatment, and that's fine. It's well known all over the world. It's head-to-head comparison with the radiation therapy. However, with higher risk disease like T3 disease or higher Gleason score, we might have a biochemical recurrence like up to 75% of cases, and this is according to literature and meta-analyses. So salvage radiotherapy with prostate bed radiation is typically decreasing the failure by about 50% at 10 years. If we see, this is a real referral for a patient who is 69-year-old patient, is referred to my clinic for salvage radiation consideration at PSA post-prostatectomy 0.14. This patient was diabetic, hypertensive, asthmatic, and he was treated for hemochromatosis in his past medical history. He had robotic-assisted radical prostatectomy in 2018. Pathology revealed BT3A, no lymph node dissection was done for this patient. Gleason's score was 3+4. PNI was positive, perineural invasion, no lymphovascular space infiltration, negative surgical margin, high-grade PIN was found. And his PSA pre-operative was 5. He did the operation, his PSA dropped to 0.03, then 0.02 for a few years. It was undetectable, then it reached 0.12 in April 2022. Another PSA test in September 2022, this month or the last month, revealed 0.14 the value. So when a radiation oncologist, any one of us, see this referral, we should have 3 questions to answer, actually. What is the definition of failure? Is this failure post-prostatectomy? Should we treat this patient with escalation of both radiation therapy and ADT? And if we are adding radiation therapy to this patient treatment, what should we do with the lymph nodes? And for the ADT, what's the optimal duration for treatment of this patient? Actually, this is a gray zone in our practice. Regarding the definition of post-operative failure or persistence, we have the most widely accepted definition from the American Urological Association. All of us know this, that the definition is when the PSA reaches 0.2 or 0.2, this is called a failure. However, there is persistence, or called the persistently high PSA, which is the PSA didn't drop to the undetectable value. And for the persistence, we need no confirmation. However, for the failure, we need one confirmation beyond the 0.2 rise. So there are different definitions of biochemical failure after radical prostatectomy actually in the world. That was in the clinical practice and the trials. Some of the clinical practitioners through the trials, they defined the biochemical failure based on one PSA rise, which is 0.2, as the American Urological Association defined, and other definitions based on sequential rising. And we might be surprised that there are some definitions and big trials that define the failure maybe even less than this. And if you see the NCCN guidelines, the new version of the NCCN guidelines, they define the failure as more than 0.1 value of the PSA post-prostatectomy, and they are clear about this. This is the Canadian guideline from the Canadian Urological Association. Post-prostatectomy patients whom the PSA is reaching 0.1, exceeding 0.1 nanogram per milli, those patients should be referred for consideration of salvage radiotherapy, and this answers why this patient were referred to my clinic at 0.14. If non-GU radiation oncologist sees this value, he might say, or she might say, oh, this patient is less than 0.2. Why we are referring this patient to the clinic? Because the Canadian Neurological Association is defining the failure is more than 0.1, not more than 0.2. When we see this, we ask where we get these values. Actually, there is the artistic meta-analysis who compared the adjuvant versus salvage. I will not go into the details, but they did the meta-analysis for 3 trials: the RAVES trial, the Radiotherapy trial, and the G12AFU17 trial. Actually, all the 3 trials define the biochemical failure as at 0.1 nanogram per milli, but the triggering value for the treatment was different between the 3 trials. Only the Radiotherapy trial treated at 0.1 nanogram per milli. However, the G12AFU16, which was not included in this meta-analysis, treated at also 0.1. So when we see this, it's also matching with the nomograms, the famous nomogram from Briganti et al., which was published in European Urology, that told us the lower pre-radiotherapy or post-prostatectomy PSA, the higher biochemical recurrence control probability. And this also matches the study from Tindoker et al. And was published in the JCO. If we can see, this is the lowest value of the PSA. It's associated with the highest value or the highest rates for freedom from biochemical failure and the lowest rates from of distant metastasis. So for patients, if you read any guideline now in the world, you will see that if you open the NCCN, if you open the up-to-date, they advise us to confirm or to exclude metastasis, to rule out metastasis at the PSA serum value of more than 0.2 or at 0.2. This is a very low value. How could we assess for that? And I personally consider to discuss PSMA PET scan at 0.15. I worked in Montreal in a very big hospital, followed trials of nuclear medicine and GU radiation oncology. They actually did many trials about this, and we used the cutoff of 0.15 for the PSMA PET scan. So regarding this patient, I already discussed with the patient the PSMA PET scan, and we will manage accordingly. But why I asked for the PSMA scan at this point? Actually, according to many studies and systematic reviews, the cutoff value of detection or accuracy of the occult metastasis using the PSMA PET scan is ranging from 33 to 45% at the range of PSA value less than 0.2 and up to 0.5. If we can see here, the Canadian Neurological Association is defining the positive prediction value or the accuracy rate of detection of the occult metastasis in the post-prostatectomy patient. If the patient has a PSA value of less than 0.2, the accuracy is about 33%. And when you are using the more advanced techniques like the gallium-68 or these novel scans, you are increasing your accuracy of detection of the occult metastasis up to even 45% in less than 0.2 PSA. But why I asked for the PSMA PET scan, and everyone here is buzzing about this in the world? Actually, 2 studies proved that the PSMA PET scan involving in the planning can improve the failure rates like the Empire randomized controlled trial and the very recent trial that was published recently by Master Yu et al. They included about 1,300 patients, more than 1,000 patients. They did the PSMA PET scan for those patients, and the higher detection rates for the occult metastasis reached about 40% in less than 0.2 and 0.5. And following the PET scan, a planned management changed in about 58% of those patients. So according to recent literature involving the PSMA PET scan in treating patients with post-prostatectomy failure can change your management, and actually the NCCN new version is telling us that it can serve as an equally effective, if even more effective than the conventional imaging. And actually, we use this routinely. I was using this during my training in Montreal. In any patient with post-prostatectomy failure, we refer the patient when the cutoff is beyond 0.15 to PSMA PET scan. Here, I use this for my patients also. I treat, like this patient had like a para-aortic and pelvic recurrence. We treated this patient with this BRT. This is another topic we can discuss in a different occasion, but for post-prostatectomy radiotherapy was the radiation field defined for a long time, but is it enough for us to treat with prostate bed only radiotherapy? It was the standard of care for a few years. Post-prostatectomy pelvic lymph node radiation has never been conclusively proven to be effective in a big trial. In definitive setting, we know that the POC-RT last year showed benefit in biochemical-free survival, progression-free survival, distant metastasis-free survival. However, the overall survival was not significant for the short follow-up. I will not go into these details because it's a different topic to treat the patient definitely. But the treatment escalation is an idea always there. The hypothesis, if we have this escalation either with ADT or with pelvic lymph node radiation or dual escalation, can this improve our outcomes? That actually was a matter of debate and a matter of investigation in few trials that investigated the ADT, not the lymph node radiation. The phase 3 GTOP trial 16 from France, the RTOG trial 9601, they added the long-term ADT. The French trial added the short-term ADT. Both revealed survival benefit. One of them showed distant metastasis survival benefit. The other showed overall survival benefit. The PSA failure decreased from 50% to 23%, 50% decrease in the PSA failure. We have the phase 3 McGill 0913 trial. I will mention it shortly. And also, we tried to add the pelvic lymph node radiation with long-term ADT and the support trial, which is a very recently published trial from the RTOG and RG. It's a very big trial, multi-institutional trial. McGill was one of the universities involved in this trial. I saw those patients on follow-up while I was trained at McGill in Montreal. And that trial actually investigated and looked at adding the pelvic lymph node radiotherapy to the short-term ADT. They classified the patient, they randomized the patient into 3 arms, the prostatic bed radiotherapy arm only, and the prostate bed with short-term 4 to 6 months ADT, and the pelvic lymph node with pelvic lymph node with prostate bed and short-term ADT dual escalation arm. And the primary endpoint was freedom from progression at 5 years. The failure, the interesting here is they used the failure definition as the Phoenix definition. So they didn't use the failure definition as the conventional trials. However, but we need to differentiate here because maybe young generation may be confused about this. They defined the post-prostatectomy failure at 0.1 and they treated at 0.1, but they defined the failure after the radiotherapy at 2 above the nadir. This should be differentiated and it should be clear for everyone. So the definition of nadir plus 2, this was for the failure of the trial, the failure of the treatment on the trial, the failure after radiation therapy. But the 0.1 cutoff was the triggering treatment value for the post-prostatectomy radiation therapy. I hope this would be clear. And the secondary endpoints, they define local failure, regional failure, any failure and overall survival and adverse events as secondary endpoint. Actually, they also use the alternative definition of failure if BSE increased or exceeded 0.4, is at 0.4 or exceeded 0.4 after the treatment. They randomize the patient in balanced 3 arms. If we see the patient characteristics, this is very important here. Those patients, most of them didn't have any seminal visible involvement. Most of them, they were PT2 stage. Most of those patients were not in a very high risk category, and the prostatectomy margins were equally distributed between positive and surgical margins. However, if we see, they excluded the patients with N+ disease, so they included only the N0 disease. And if we see also, if we dig into the details, the Gleason score they included for these patients who was 7, most of them was 7, either 3+4 or 4+3. So they define the target volume as the usual target volume up to the level of L5S1. This is very important because I will mention it shortly. And the dose they used is the conventional dose. They treated the pelvis with 45 to 46 gray, and they treated the prostate bed up to 72. We use usually 62, and we can boost if there is gross disease or the PSMA PET scan or something to up to 70 or 72. The freedom from progression at 5 years was significant between the 3 arms, differently significant. And also, if we can see the arm 1 versus arm 3, which is using both for dual escalation, is very, very superior to the prostate bed only radiotherapy, including the pelvic lymph nodes with short-term ADT with dual escalation, had the highest rate of freedom from progression and the lowest rate for the distant metastasis. However, for the distant metastasis, that wasn't translated into survival function, and the only significant is to use the dual escalation versus the prostate-only radiotherapy. And if we see this forest plot is the subgroup analysis, we can see that maybe the only significant, it's all significant if you treated pelvic lymph node radiotherapy with short-term ADT versus versus prostate bed radiotherapy alone. It's all significant in the subgroup analysis. However, the outcome regarding the freedom from progression was also significant between arm 2, which wasn't including the pelvic lymph node, versus prostate bed only radiotherapy. This is the arm all the world asked about it. What is the difference between adding the lymph node pelvic radiation to the ADT? Is it a good idea? Is it effective to treat this with pelvic lymph node radiation? As we can see on the forest plot, in all subgroup analysis except the median PSA. Here, if we can see, it's a marginal improvement if the median PSA is less than 0.35, and this would be a question. If there is a cutoff, we can treat with pelvic lymph node radiation, or there is a cutoff below it, we shouldn't add pelvic lymph node radiation. However, that was translated, as I said, as crude rates, significant difference. For the acute events, acute adverse events, we can see that the GU and GI grade 2 toxicity was higher in the pelvic lymph node radiation, and this was actually expected, and it's matching previous and other trials. It's limited increase in the toxicity. However, it's a highly significant increase. But for the late adverse events, there was no difference between the 3 arms in the late adverse events. So in conclusion, we have now strongest level 1 evidence supporting the pelvic lymph node radiotherapy with short-term ADT. And the question is, for arm 3 versus arm 1, we use either we use dual escalation or we use prostate bed only. This is not a question anymore, because that was very, very significantly different between the 2 arms, and we need to treat 6 patients to prevent 1 patient from progression. Follow-up is needed to differentiate between arm 2 and arm 3 should we add pelvic lymph node radiation in a certain cutoff for the PSA or not. Also, the role of PET scan is a matter of debate, PSMA PET scan, to define the pelvic lymph node radiation, whether we treat those pelvic lymph node with SVRT or not, because most of the trials actually said that the recurrence after prostatectomy would be in the lymph nodes. To wrap up, these are the 3 big trials that looked and investigated at the post-prostatectomy management. The GTOG16 trial, they investigated and they added the short-term LHRH agonist that revealed distant metastasis-free survival, metastasis progression-free survival benefit, biochemical recurrence-free survival benefit. The GTOG trial the OncoEgypt trial also, they added the long-term ADT, but they didn't treat the pelvis, and that showed also benefit in the metastasis progression-free survival and biochemical recurrence-free survival. The recent support trial, as we mentioned, they used the pelvic lymph node radiotherapy with short-term ADT, and this arm actually was superior to both of the other arms. I will quote here the conclusion of the trial. The new PET tracers confirm that the recurrence of primary or salvage radiotherapy treatment is often in the lymph node. And based on that node recurrence, we can define our management, and that was based on the lymph node recurrence distribution studies. Also, they suggested further extension of the lymph node treatment volume superiorly. If you remember, they used the standard definition and they stopped at L5S1. Here they are also recommending to extend superiorly, and that was done recently actually for the RTOG atlas for contouring the pelvic lymph nodes in the prostate in both the post-prostatectomy settings and the definitive setting. They actually recommended to go up to L4, L5, and this was updated in the recent RTOG atlas. In conclusion, extension of the standard post-prostatectomy salvage prostate bed radiotherapy fields to include the whole pelvis with to treat the lymph nodes, especially when used with short-term ADT, was found to result in the greatest impact in outcomes in the support trial. One last thing, the McGill 0913, I'm one of the co-authors of this trial. We are doing the long-term update data. We actually doubly escalated the treatment using the long-term ADT and the whole pelvis radiation therapy. We doubly escalated the treatment. I hope this will come soon.
We are running out of time.
Okay, this trial is actually under review and will come soon. Thank you so much.
Thank you. Thank you very much, Dr. Marwan, for this comprehensive and very nice presentation in a point which is having many debates. Thank you.
Thank you.
We have one question from Dr. Huda.
كيف حالك؟ عامل ايه؟
أهلا دكتور هدى، ازي حضرتك؟
I would like to ask you about
الحمد لله. أنا ليا الشرف طبعا، اتفضل.
Usually, the problem of the lymph nodes that the dose for the cancer prostate is very high. At the normal, it's 80 gray, more than 75, 76 gray. And you think that this dose to the lymph nodes is effective. The dose to the lymph nodes should be very high, and the complication is also very high. And also, what the volume of lymph nodes, you stop adding
دكتور هدى، أنا مش قادر أسمعك كويس، بس معلش آخر حاجة إيه؟
The dose to the lymph nodes should be very high to be effective. And so
yes.
The complication also will be high. This is the problem of the lymph nodes. And also, what the cutoff of size of lymph nodes, you will stop giving radiotherapy. The level and size.
Cut off of the lymph node.
If you find a big lymph node, you still give radiotherapy. If you have the lymph nodes big size, you still give radiotherapy to the pelvic lymph nodes or to the para-aortic lymph nodes?
So actually, Actually, we have trials of escalating the dose to lymph nodes. It's called the BR22 trial, which is a basal high-cap trial. It's between Australia, Canada, and the US. And this trial actually is looking at maximizing the doses to the pelvic lymph nodes. Usually, we use the escalated dose to the lymph nodes up to 56 gray. We usually try to keep it as low as possible for the normal tissues, because everyone now is using the BMAT techniques. Everyone now is using the SPRT techniques. So I think regarding the bowel toxicity, we do a good job in preserving the bowel toxicity. We do this on a daily basis, and we don't see so much bowel toxicity in this. And this actually was evident on the trial that they say that the grade 2 toxicity, GI toxicity was higher, significantly higher, but it's limited in crude rates, and we can manage this. This is comparable to other trials. If I understood your question, I'm not sure this answers you or not.
Yes, because still we have, I think that this still, those 56 or 65 gray is still not efficient for cancer prostate. You need a higher dose.
I forgot to mention that we use hypofractionation, so that dose is very high. We use 60 in 20 for the prostate and 44 in 20 to the pelvis.
Thank you.
Thank you, Dr. Bilal.
Thank you, Dr. Marwan. Now it's my pleasure to present the next speaker, Dr. Hani William Zaki, consultant and the head of Clinical Oncology Department, Ahmed Maher Teaching Hospital. His presentation is about pelvic nodal irradiation, do or not to do definitive prostate sitting.
Thank you. First of all, I thank the organizing committee and Dr. Rima Ahmed for inviting me, and thank you my professor, Dr. Harabai, Dr. Sumaya Izzat for attending, and my colleagues and my friends in Ahmed Maher Hospital, especially Dr. Duran Muhammad for helping me in the presentation. From Dr. Marwan ended by pelvic irradiation post-operatively, and we say just introduction prostate cancer ranked the second after lung in the incidence and the sixth in rate of mortality. The patient with prostate cancer, the mean age about 70, diagnosis with BSA in screening cases, then biopsy with ultrasound MR guided, the staging of prostate by MRI and the bone scan conventional, and recently the plasma scan will be the standard of care. 95% of cases are non-metastatic, but the patient with prostate cancer, very heterogeneous group, some of whom die from prostate cancer. This patient is a slow-growing and also progressing tumor. The journey of the prostate cancer started from clinical localized, and then localized treatment with radio or surgery, follow-up rising BSA, be metastatic non-castrate, then castrate resistant, and first, second line systemic treatment. Once the patient has detectable metastasis, the deaths from cancer exceeds those from other causes. So the identification of patient with high risk for pelvic or death summit should be recognized. All of the recognition definition agreed for Gleason score from 8 to 10 and BSA more than 20, and some use T2C or T3A as a stage 4 high risk. One of them equal high risk patient. NCN more specification the high risk into high and very high risk. The high risk have no very high risk features with one of T3A or grade group 4 or 5, BSA more than 20, very high risk T3B or T4 with primary grade Gleason pattern 5, or 2 to 3 from the high risk features, or more core grade 5 or 4. These high group features as know the role of radiotherapy in prostate cancer as curative or post-radical prostatectomy or palliative. The high-risk patient, we search for the pelvic lymph nodes. And from the Marwan talk, the role of adjuvant radiotherapy in pathological lymph nodes have a benefit of 8% overall survival, adding ADT with pelvic irradiation, which also proved in the RTOG 0534. Sport show a benefit from addition of ADT to salvage prostate bed radiotherapy, and also further gain from addition of pelvic node irradiation. So our patients are treated with radical radiotherapy. As you know, the treatment of localized ulcer surgery, but I think most of cases in Egypt treated with definitive radiation therapy. So in patients with high risk pelvic nodal disease, use of elective nodal radiation is still a controversial, take or not to take in our field size. Firstly, we must know the lymph node drainage of the prostate. The prostate drain to the obturator downwards, laterally to the external iliac and ascending to the internal and the common iliac, and posteriorly to the presacral lymph nodes. This group of lymph nodes must be covered in case of pelvic irradiation. But how to identify? The baseline BSA and the tumor stage and the Gleason score are predictive of lymph node metastasis. And the Roche formula, as we know, approximate the likelihood of lymph node metastasis commonly calculated by the clinician. Lymph node probability 2/3 BSA plus Gleason minus 6 times 10. And also the imaging modality to identify lymph nodes as CT, MRI rely on the size and shape to determine metastatic with threshold more than 1 centimeter, which, however, the lymph node less than this size are positive. And the help of new imaging as PSMA and the MR lymphography. In these two cases, the first one in A, lymph node about 5 millimeter metastatic in the CT, proved by gallium PSMA scan to be positive. And also in the picture C, 3 millimeter metastatic internal iliac node visualized in T2, proved positive by MR lymphography. So the new modalities of imaging help us to detect a smaller lymph node size. So identification of lymph node either by the clinical factor or Roche formula or imaging. So this patient for high risk negative or clinically negative node and prostate cancer patient. The value of whole pelvic radiotherapy in this patient by many trials, RTOG 9413 trial, randomized 1,300 patients to 4-arm study with the primary endpoint progression-free survival. JTUG 01 trial, randomized more than 400 patients with primary endpoint event-free survival. A BOB-R trial with biochemical progression-free survival as endpoint. We'll discuss the first three trials. In the RTOG trial, the sequence of hormonal therapy and radiotherapy failed in unfavorable localized cancer with Roche formula more than 15% risk of pelvic node, randomized to 4-arm, neoadjuvant hormonal followed by whole pelvis, neoadjuvant followed by localized prostate, or whole pelvis followed by adjuvant 4 months hormonal, or localized followed by 4 months. The winner arm in the progression-free survival was localized radiotherapy to the prostate with adjuvant hormonal treatment with 10-year progression-free survival 30.2%. And the toxicity go to the whole pelvis with neoadjuvant or adjuvant hormonal treatment in the bladder and GIT toxicity. This trial, update of the trial, there is no longer report on overall outcome of whole pelvis versus post-operative versus localized prostate radiotherapy and neoadjuvant versus adjuvant hormonal treatment, so it is a negative study. The French study studies the role of pelvic irradiation in localized prostate adenocarcinoma, more than 400 patients, design assigned to pelvic node plus prostate or pelvic or prostate-only radiation therapy, and the patients certified into low risk and high risk. The high risk is a T3 or Gleason more than 6 or BSA more than 3 times the upper normal, and low risk group early T1 and T2 and the Gleason 6 and BSA less than 3 by times upper normal. The hormonal therapy in this trial was 6 months only for high risk. The radiation therapy was 3D to the pelvis, 46 gray for the pelvis, and 70 to the prostate. The overall survival for the whole group with median follow-up 11.4 years. The 10-year overall and event-free survival was similar in the two treatment arm, either low risk and high risk. So still no evidence from the previous two trials. The prior JET UG01 trial demonstrated no benefit of pelvic nodal irradiation using relatively small field size limited to the superior border at the S1, S2. The superior border in the R2G trial is L5S1, which is inadequate and does not cover the common iliac lymph nodes. The surgical series have demonstrated a high frequency of prostatic lymph node drained beyond this landmark, and also toxicity is high with pelvic nodal irradiation, and this trial used short-term hormonal treatment. The third trial, BOB-RT trial, which you compare prostate only versus whole pelvic radiotherapy for node negative with Roche formula nodal risk more than 20%. The patient in this trial include stage 1 to 3A with Gleason 8 to 10, Gleason 7 with BSA more than 15, Gleason 6 with BSA more than 30, or T3B, T4 with any Gleason, any BSA. The patient unrandomized 1-to-1 randomization, localized radiotherapy 68/25 hypofractionated to the prostate versus whole pelvis to 68/25 for the prostate and the 50 gray to the pelvis, including the common iliac lymph nodes, which is not included in the previous two trials, and the androgen suppression for a total duration of 2 years, which was 6 months in the previous two trials. The biochemical failure-free survival was 95 in the whole pelvic group versus 81 for the prostate only, with significantly p-value 0.001. The whole disease-free survival also improved in the whole pelvis with about 90 versus 77 with significant p-value, but overall survival did not appear to differ with p-value 0.83. Distal metastasis-free survival also higher with whole pelvic irradiation. From this trial, prophylactic whole pelvic radiotherapy using contemporary dose and technique along with long-term ADT for high risk and very high risk prostate cancer resulted in a large and significantly improved biochemical failure-free survival and disease-free survival compared with radiotherapy to prostate alone, but did not impact on overall survival. This study by Sparta et al. Defines the upper border of pelvic radiotherapy. The upper border in GTU French trial was S1 and S2, cover only 33 of the failure. By the upper border at L4, L5 cover 93% of failure. So in the planning of for pelvic irradiation, the upper border should be at L4, 5 to cover the common iliac lymph nodes. The comparison between the four trials, the pelvic upper limit in R2EG 94L5S1, in GTUG trial S1 and 2, pivotal trial L5, BOB-RT trial L4-5, common iliac included. The dose to the prostate 70 conventional in R2EG, 66 to 70 in GUTG with prostate biological effective dose 106. In the BOB trial, 60 hypofractionation, 2.6 per fraction, and the hormonal therapy was 24 months for BOB trial and intensely modulated radiation for the BOB trial. Till now, we have no consensus, and we wait the R2EG 0924 is a major large-scale randomized controlled trial currently open with primary endpoint of overall survival. The first one, the primary endpoint is overall. It aimed to recruit over 2,500 patients with high risk or unfavorable intermediate risk and to compare the efficacy of ADT in combination with either prostate alone or whole pelvic radiotherapy. The patient is stratified, LHCO group 1 Gleason 710 and T1C22B and BSA less than 50, or gleason 6 and 2T T4 or more than 50 positive biopsy and BSA less than 50, or gleason 6 T1C to 2B and BSA more than 20, type of radiotherapy boost IMRT or brachytherapy, duration of androgen deprivation, short-term or long-term, and the randomization will be arm 1 neoadjuvant androgen deprivation therapy, short or long, plus prostate only. The phase 1 prostate plus seminal vesicle 245 gray, and the phase 2 prostate proximal seminal vesicle versus arm 2 pelvis then boost. So we wait long-term outcome will therefore not be available for at least another 5 to 10 years. Until then, the role of pelvic nodal irradiation in prostate is likely to remain a continued source of debate. Thank you. Thank you.
Thank you, Dr. Hani.
It's a pleasure to introduce my dear colleague, Dr. Ahmed Amin, lecturer of radiation oncology at NCI Cairo University, and he is the head of the radiation oncology department in Bahia Hospital, and he will give us an idea about Bahia experience in SPRT.
Good afternoon, chairpersons. Good afternoon, everybody. It's a great pleasure to be here. I'd like to thank the organizing committee, Dr. Khaled Abdelkarim, Dr. Reem, for my invitation. We're way behind our scheduled time, so I'm going to present this, make it a very, very quick presentation. It's about the spinal SPRT. I'm really glad that we are doing this so often in my hospital. I'm sure we all agree together that whenever we're having metastasis, even if it's limited or oligometastatic, we have to consider our treatment as a palliative treatment. We have to discuss with the patient, even with some potential cure, but we have to agree that this is considered as a palliative treatment until we're having a very strong evidence that this should be included in our guidelines. So what's the evidence so far? The evidence is the retrospective data from MD Anderson that's proving that the patient who are having no evidence of disease, they are doing well in terms of overall survival compared to the patients who don't have evidence of the disease, or have the evidence of the disease. We also have some phase 2 trial evidence that are giving some advantage to the patient who are receiving SPRT compared to the control arm who are treated only with systemic treatment. So nowadays, actually, we're gonna, every one of us, we're practicing SPRT to the spine more often because we're having, but before considering this in your hospital, you have to make sure that you're having some advanced imaging machines like PET-CT. Your patients are really indicated for SPRT, and to have a clear indication to select proper timing. For example, you might consider chemotherapy before to make sure that this patient is not going to develop any other metastatic site, to properly select the patient, properly select your target volume, check your organ at risk proximity, and to have the advanced machines and the enough experience, and this should be done within clinical trials. We are doing that these days so often because we're having early detection programs. We have improved diagnostic tools. We are having improved systemic therapy that are providing us with patients who are having very limited disease. We're having a very advanced radiotherapy machines, having cone beam CTs and 6D couch and very thin MLCs. We're having stronger evidence and better experience, and this is a very interesting area of research. That's why we're doing it. Today, I'm just going to discuss the spinal SPRT. For breast cancer, actually, the most common sites for metastatic directed therapy are the cranial SRS and the SPRT for the spine. For the SRS, we're having some workshop of next weekend, so you're all invited if you want to attend. We're going to cover this subject in details. But today, I'm going to give you our data about the spinal SPRT. For spine, I'm not going to talk about the technical issues, but they're having very interesting data from the ASTRO that are defining the proper patient for SPRT. You're encouraged to use this. For me in my hospital, we are using this data to select or to properly select our patients before prescribing SPRT treatment. So you have to remember that it's always okay to take one step back. So even if you prescribe SPRT for a patient and then we had this before. We had a patient, we were almost starting with the treatment, but we discovered that the patient was not that stable on the machines. She had some psychological problem. We aborted treatment. Even after prescribing treatment and MDT decision and the plan and everything, we just aborted. So it's always okay to change your mind. We're not going to talk about the technical issue due to the time, but I have to tell you, give you a few of our data. Remember that SPRT, it's supposed to be safe treatment when it's conducted properly, but we might get some side effects, especially myelopathy, vertebral compression, especially with high doses, pain flare. You always should consider dexamethasone for your patient, because pain flare without dexamethasone might reach 68%. But in general, it's well-tolerated treatment. Remember, bowel toxicity for this patient has a very proximal bowel to the vertebrae. You have to to define the proximal organ properly. When you have proximal organ like this patient, the esophagus was very close. You can just edit the esophagus outside your PTV. You have the right to do this. And for site consideration like cervical spine, you might consider contouring the constrictors and other structures to make sure that they are safe. We need experience to have good planning. We have to have good physicists and expert physicists. So having good plans differ a lot in your toxicity profile. Our experience, we're having 5 years experience now in spinal metastasis treatment. We did 34 oligometastatic breast cancer patients in the last 5 years, actually. For local control, we're having 85.2% local control. Only 4 of our patients had progression. But I'm talking about local control. I'm not talking about systemic disease. Some patients, they develop mets at other sites, or even they passed away, but I'm talking about the local control. Progression-free survival data, we're still not available. We didn't analyze the patients so far. And for other primaries, we're doing almost 3 patients per month. There are patients who are referring to our center especially for SPRT, but we don't have any further data regarding their follow-up. So they're just experience for our physicists to perform this technique, but we can't publish this data. We don't have their data. Most of our treatment sites are in the lumbar region or the dorsal region, and we can also do for the sacral and cervical spine. Toxicity, we're lucky that so far we didn't have that significant number of toxicity. Just 1 patient had a vertebral fracture, which is a common side effect, by the way. And for the pain flare, it was not properly assessed. We are assessing it now, but in the beginning of our practice, we were not assessing it properly. But at least 7 of our patients, they had flare phenomena with the treatment. Okay, this is just some slides from our patients, and that's my take-home message that SPRT is a promising therapy for patients with spinal metastasis. Its role is still under investigation, but most of the published data are supporting its potential survival benefits. To conduct such advanced techniques, certain levels of experience and technology must be available to ensure its safety and efficiency. Thank you so much.
Thank you very much, Dr. Ahmed. Thank you very much.
It's okay now to conclude the session. We'll leave the room for the quality. Thank you very much, and thank you for all the speakers. Thank you.